All right, so now we are recording, and I hope that you can see my screen as well. Yes, perfect. I always want a feedback, and probably that's just me being an educator, where I always want a feedback from the students, whether I am conveying the right message or not. So, thank you very much, everybody, for dialing in and also for making the time to attend this session. I'd like to begin, and this is an Australian tradition where we need to acknowledge our Aboriginals and Torres Strait Islanders um, who are the traditional custodians of the land. So I'd like to acknowledge the Aboriginals and the Torres Strait Islanders being the traditional custodians of the land, and also to the elders. I pay my respect to them, uh, past, present, and emerging. And thank you. Welcome to our demo class. I know that MADS as well, and I like the word RN in there. You've put that RN, that's really good. Good morning. I'm not sure which part of the world you're calling in MADS, but it's good morning here in Australia, so good morning. Um, and I know that Jane is in Qatar as well, 2 a.m. in the morning there. So good morning and good evening, Audrey. So it's really good to see everybody around the globe. And thank you again for dialing in, because you really made time to be part of this demo class. So we are from Nursing Education and Training Australia. My name is Carissa. I am one of the nurse educators, and part of my role is a nurse manager, and also the operations as well, where I do some of the admin work also for NETA. So we are the provider of the outcome based assessment, and we would say that we have about 97% passing percentage of NCLEX, and always it's not perfect. There's always room for improvement. So 97% for our NCLEX, and also we have already passers in our OSCE. So we are very proud to be the institute that has the only passers for our OSCE. So I am very proud of that. And also the educators who have guided the OSCE candidates. So we are located in Australia, but definitely um, this is how the world works now. We are very reachable. Across the globe. So we do have our agents as well across the globe if you would like to utilize the agents if you need some help. And you can also message us directly if you want to. So today we will be discussing about user applied labeling of injectable medicines, fluids and lines, which is based in an Australian standards. Um, Karen is here with me today. She is the OBA course coordinator, and she will um, be introducing herself. So, Karen, would you like to introduce yourself?
Yes, definitely. Some of you already heard who I am, but yes, for those who just joined, I am Karen. So my name is Bevelyn Karen, but it's easier to call me Karen. I am the OBA course coordinator. At the same time, I'm a nurse educator. I am an Australian registered nurse. So just like for a few of you here as well, who has been a registered nurse somewhere else in the globe. So I am the same. We are internationally qualified nurses and are now um, practicing and a registered nurse here in Australia. So I am the person who you are going to be, in touch with regards to your classes, with regards to the course, with regards to any inquiries regarding OBA. At the same time, I'm also a director of nursing on one of the day surgery here in Melbourne. So we are proud to say that our educators are of high caliber. They are leaders in their respective field of specialization. So I'm also proud of that. As Carissa is proud, and I am proud of our pastors, we are also proud of our educators who are helping hone our students to be a registered nurse here in Australia. All right. Thank you, Carissa.
Thanks, Karen. I'm just saying hi to Shima, who's shared her camera. Thank you so much, Shima. Peace. um, I can see it's a bit dark there, Shima, so I would presume that you are somewhere to the west side of the globe. Yes. All right. So thank you, Karen. And we will be starting our demo class. So the user applied labeling of injectable medicines, fluids and lines is based on Australian standards. So we are all internationally qualified nurses and I want to ask from everybody, are you familiar with the labeling of injectable medications? And anyone can just talk or pop out.
Yes.
Do you do it in the UK, Audrey?
Yes. But I currently work in the theater as a scrub nurse, so we don't use as much injectable medications as a ward nurse would do. So on a daily basis, we only use adrenaline that we incorporate into saline solution 500 mils, but we always need to put the labels that's been printed for us to just stick it in the bag and just fill it out with whatever medication is in there. And the
Perfect.
usual, the date and time and the name of the person
Mhm.
that did it, or whether it's with someone else or just by yourself.
That's really interesting. The reason why I'm asking because UK practice and Australian practice may have some similarities. And I think this is something that you already learned, but then we'll learn it in an Australian way where we do have color coding. Even in theaters, we do have the sterile packs of the labels, and each
Mhm.
medication will have their own labels as well, so as color coding. So it will be very interesting for you to see the difference.
Yes.
Um, Sarayo, welcome. We have just started and we were just talking about labeling. So please feel free to unmute yourself, Sarayo, if you would like to talk. Um, and please feel free to be in the conversation because we are inclusive, as what we said. All right. So, who else have done some labeling in their home country where they practice? Anyone else? Maybe familiar or not familiar? Sapana, are you familiar with this medication labeling?
Um, I'm originally from Nepal, and the labeling is quite different in our country than in Australia. In Nepal,
Mm,
we used to label the syringe and medicine by the permanent marker, writing the date, time, and medicine name only. That's why it's
right.
that's difference. I
Yeah.
think so. Yeah.
Renu, you want to say something?
No, actually, I agree her answers, because in Nepal we don't have any like printed levels. We just write with the marker, the medicine and the components of the medicine. We mix with it in the saline time, and we don't put our name in the labels. Yeah.
Right. So it's very interesting how different countries would work. Definitely, the principle is the same. For us to be able to administer the medication safely, labeling is one of the safety measures. So there are other safety measures that we would need to consider, and that is part of our standard four in the national standards. So I hope you have received the new information about the RN OSCE that was released by the NMBA on the 23rd, was it 23rd? yeah, 23rd of March 2021. We actually made a video of that as well, explaining the new process. So um, that will be posted as well in our Facebook page. So if you follow our Facebook page, you will be able to also see the changes that has been applied by the NMBA when it comes to the OSCE RN examination. Well, OSCE already has examination, so OSCE RN. So yeah, so the user applied labeling of injectable medicines, fluids, and lines is part of the Standard 4. Anyone who can tell me what Standard 4 is? So in our OSCE classes, we are very specific with the standards because this is one of the resources that APRA actually highlighted that every registered practitioner should know. So the national standards would be standards 1 to 8, and we do have standard 4, which is medication safety. So this is part of standard 4. It is also a vast topic, so we will be doing other demo classes that would fall under standard 4. Um, Another part of Standard 4, aside from labeling of medicines, fluids, and lines, would be the quality use of medicines. And this is where the antimicrobial stewardship will intertwine, which is part of Standard 3, which is the prevention and the controlling of infection, hospital acquired infections. We also have another component of the medication safety standard, which is the high risk medication. And we have the acronym APINCH. So if you don't know that yet, keep posted in our Facebook page because we will be also doing a demo class for that. We also have the National Inpatient Medication Chart. So this is very different from your home country as well. And this is something that you also would need to learn. So we have the the national standard of the medication chart. So all of Australia will be using this chart, and definitely this is something that we would teach the students so that during their OSCE, they know what kind of charts they will be using. Another one is labeling of medicines, which is this one, and also the National Tollman lettering, which is very new, I know. This probably would sound so new to you, but these are the look alike, sound alike medications that we use in Australia. So keep posted for demo classes with these components of the National Standard 4, which is medication safety. For today, we will be focusing on labeling. Any questions so far before we proceed?
None po. None so far.
Yeah.
Thank you.
Perfect. So let's go on to the facts first. So the fact is that there are the injectable medications. When we talk about injectable medications, these are medications that are um, given intravenously or um, subcutaneously or intramuscular or intrathecal or intraosseous. So these are the medications that are injected into the body. So they are considered high risk medication. And as registered nurses, you will know that why they are high risk medications is because they can give immediate effect to the body. So with oral medications, we're thinking about 30 minutes to an hour before it takes effect. But with IV medications, in just 5 minutes, if you've given the wrong medication, it will give an effect already to the body. So it has been, there's the study shows that 25% of medication incidents involve injectable medicines. So 25% is actually a high rate. That is a quarter of all injectable. Of all incidents. So, what does that mean? It is quite alarming. So I'm not sure if you've heard the story as to one of the reasons why we have this medication labeling. It was a story, and you can search this as well in one of the even in YouTube, you can see that this has been in the news. So there was one pregnant lady trying to, give birth, and this woman actually was given chlorhexidine epidural instead of the anesthetics. So this epidural has gone, this chlorhexidine has gone through the epidural, went to the epidural space, went to the brain, and then obviously chlorhexidine should not be inside the body. So the brain did swell. What happens to this woman now? She could not touch her baby. She could not hug her baby, and but she's still alive. Good thing she was here in Australia, but definitely it's the quality of life that has been affected. So she's paraplegic till now. So you can see that video if you watch Grace Wang epidural incident, and during the fact finding, the recommendation in 2012 was to label injectable medications. So this was one of the recommendations, and that's the reason we are labeling medications now. So out of that 25% of injectable medicines, 60% of that 25% actually result in patient harm or death. Okay, so there could be incidents of, wrong vitamin C injection did not harm the patient. That's fine. It's a medication error. It's vitamin C. The patient's not allergic to vitamin C. It was just an error. Or a dexamethasone was given to a patient, probably who doesn't need dexamethasone. That is also fine. I mean, it's not fine. It's a medication error, but it did not cause a patient's harm. But out of that number, 60%, that's more than half of the incident. So 60% of those did cause serious patient harm or death. And what does that mean? This is very serious, and that is the reason why, as entry level registered nurses, the NMBA is very particular that during your OSCE, you know how to label the medications, because this is a safety issue. In OSCE, at the end of the day, what they really want to see is that number one, you're competent to do the skill. Number two, you're confident to do the skill. And that includes your communication to the patient. Number three, you have followed the standards of practice, whether it's national standards, the RN standards of practice, or the professional standards that includes your code of conduct and code of ethics. And of course, number four, are you a safe registered nurse to look after the Australian community? So imagine if you are the assessor. The assessor would think, can I let this nurse look after my family? If the order of the medication is intravenous, and here is this nurse giving this orally to my patient, is this nurse safe to look after myself and my family members? So these are the key points that you need to remember. Any insights, questions, suggestions before we move into the next slide? That is the reason, by the way, why I did not have an epidural anesthetics when I gave birth to my first son, because the news was so fresh at that stage. All right. So, what are the principles in labeling the medication? So, number one, all medicines and fluids removed from the manufacturers or hospital pharmacies' original packaging must be identifiable. So, anything that you, as a registered nurse, remove from the packaging, you hang it in an IV pole, for example, there's no label. You need to identify what it is. So, it needs a label. Okay, so anything that is being removed from either the manufacturer or the hospital's pharmacy's original packaging, where there is the label, it needs to be labeled. The next one is all containers containing medicines leaving the hands of the person preparing the medicine must be labeled. So if you are preparing a heparin injection, you put it in your kidney dish, that is already out of your hand. Okay, so you need to label that medication. You need to label that syringe. So anything that is that leaves your hand, that means that it is a disturbed process. Because when you say undisturbed process, it is you are withdrawing the medication, did not leave your hand, administering it straight away. You don't need to label that. But if that particular medication or IV fluid is out of your hand, you need to label it. The reason is because if there would be an emergency, you are going to leave whatever you have prepared in your kidney dish, right? Because you need to attend to the emergency first before you administer a medication. And that is obvious when it comes to prioritization. You don't want that medication to be left unlabeled. Either another registered nurse would see that with pure intention of helping, your medication chart is there, they might administer that medication. But me as a registered nurse, if I don't know that medication, I will leave it. I won't give it. But there are other nurses. Maybe it's because everybody's too busy, overwhelmed, and their intention is to help. And there is like that presumption. Oh yeah, it's Carissa who prepared this for sure. Carissa checked its heparin, 5,000 units, subcut. This must be heparin. But maybe my patient was vomiting at that time, and I wanted to give ondansetron, for example. So that would cause that miscommunication. So anything that leaves the hand of the person needs to be labeled. There should only be one medicine at a time that should be prepared and labeled. So if you have multiple antibiotics, you are not, it is a recommendation, and the best practice is to um, do the preparation one at a time, because you will be dealing with different injectables. And that is a very good room for error for you. So it is a recommendation, and it is a principle that we follow, that there should only be one medication prepared at a time if it is an injectable medication. Any medicine or fluid that cannot be identified is considered unsafe, and therefore you need to discard that. So these are the principles that you will need to know when you attend your OSCE in Adelaide. So how do you apply that in OSCE? So the first thing is, as an entry level of a registered nurse, you are expected to follow the guidelines of labeling. And that is from the preparation up to administration. Okay, so each medication route, the medicine class, and the designated line has a designated color coding or labeling, which I will show to you later on. Is that understandable at this stage? Is that clear? Yep, you're all on mute, but I can see everyone nodding their heads.
Yes.
All right, so let's move on to the labels. So these are the different types of labels. These are three out of the so many, and I'll be showing you more as we go on with the slides. So these are the labels that you would most likely use as a registered nurse. The first one is intrathecal. Now, when we talk about OSCE, intrathecal is quite an advanced practice. So, as an entry level registered nurse, you will not be administering or manipulating intrathecal medications until you have the competency. Okay, and that would probably be after you become a registered nurse. The only thing here that I want you to know is that know the label itself. So intrathecal are yellow, and if you can see that the side is quite solid. Okay, others would have the hatch. We call them hatch. What do you call hatch border? Okay, but for intrathecal, it's a solid border of yellow. And what does that mean? If you see that this is an intrathecal label, as an entry level registered nurse, it is a good to know for you. Okay. The next one is the one that you will use quite often, and this is for intravenous use. So, any medication that will be given intravenously will need to have the label that is blue, and the border is hatched black and blue. Okay, so that is any intravenous medication. Now we do have that label, and this is the sticker. It is a sticker label that you will fill out with the patient's name, ID, date of birth, what's the medicine, what's the concentration, what's the diluent, the date and the time. But you can see here the preparation. So it's prepared by and checked by. So any injectable medication needs to be done by two nurses from the preparation to administration. Okay. There has been a question. Oh, I already checked the medication. Yes, you did check the medication, and that is good. During the preparation, you did check. Did you know how much meal per hour did the nurse set? Okay. It might be a magnesium sulfate, and you need to give it as a slow IV. What if the nurse that was administering that medication has set it to say, 500 meals per hour, which is very fatal? So, would you allow that to happen? Your signature is there. Therefore, you need to be there from the preparation to the administration of that IV fluids. What's the color again for intravenous? You're all on mute.
Blue.
Blue.
So,
Perfect. So it comes in different sizes. So this one is the largest size, and I think it's got the large label, 100 mm by 60 mm. So you can see that there. Um, then the smaller size is 60 mm by 50 mm. So the smaller size is actually for the syringes, because there are intravenous syringes that you're going to give. And also it can be for burette as well. Okay, there is a designated line, and that means that is only for that intravenous fluid, for example, like a maintenance fluid, and um, it will also have a designated IV label, which is also blue. So I'll show that to you. So you can see that that is the um, bag with the IV fluids. So you can see that. Um, you can also see that the label is attached there. Question: are you going to attach that at the front? Yes, according to the standard and the recommendation, it should be at the front. Okay, why do you think so? I'd like to check from everyone. Why do you think it should be attached at the front? Any guess?
I think the contents of the IV fluid or the expiry date will be in the front, and
Mhm.
so the back will be cannot be visible.
That is exactly right, Renu. So aside from the expiry date, you can also see the name of the fluid and the batch number. So if there are any medication adverse reaction, for example, it takes 2 to 3 seconds to actually look for the label if it is at the back. Okay, and that 2 to 3 seconds actually is very significant in saving somebody's life. Therefore, it is recommended that you put it at the front without covering the fluid name, which is, say, sodium chloride, the batch number, which is something DS something 88N9 in there, and then the expiry date as well. Okay, so do not cover that, but put your label at the front, and that is a recommendation. Um, you might be able to see in some practices that they still put that at the back because before this standard came out, there was a different IV label, and it was a practice to put it at the back. As a registered nurse, newly registered nurse, we need to follow the best practice. So it is okay to let your fellow nurses know that, oh, I have noticed that you've put it at the back. I was taught that it should be put at the front. Okay, so that is a good way of saying it. All right, for syringes, this is a small label. Um, and this is to cover, not to cover, sorry, it is to label the syringe. So it is best practice to actually not to cover the calibration. Okay, so that's the reason why we ask our nurses to actually flag, and that's how you are going to flag it. Okay, so that is how it looks like in a syringe. Question: do you flush the IV cannula in your home country where you practice before administering an IV medication? There is a chat here from Mark. So we can see it immediately. That's correct, Mark. Thank you for sharing your thoughts. So as Sapana, everyone can see from the front easily. That is correct, specifically in emergency cases. Okay, so if there's an emergency, the patient has ongoing, say, calcium gluconate, for example, and then you can see, oh my God, it's calcium gluconate and it's running at 500 mils per hour. Maybe this patient has a cardiac arrest. You go straight to your CPR because you already have the intuition, or you already have that, pre-diagnosed cardiac arrest, probably because of the calcium gluconate that's running really fast. Okay, so that's the reason why it is put at the front. Thank you guys for sharing your thoughts. Just a question about flushing. Do you normally flush? Is it a practice back home?
Yeah, we do flush.
Good. What kind of flush do you normally do?
Normal saline.
Perfect. Do you label your normal saline?
Uh, no. Actually, we take it when we like when we give medicines to check the patency of the IV line. So we don't. Actually, we write flush, in the syringe.
Perfect. So same principle, you write flush. In Australia, there is a designated label. And if you can see this sticker, it's uh, white in color and it says sodium chloride 0.9%. So this is a sodium chloride for intravenous flushing. So you need to label your flush as well. Tendency is if you both have 10 mils of medication, um, specifically antibiotics that are really clear in color, for example, ampicillin, for example. When you go to the patient's room, you wouldn't know which one is a flush and which one is a medication. You might flush it with ampicillin and then administer normal saline and flush again with ampicillin. Okay. Which is not a very good practice. It's not the best practice. So therefore, you need to make sure that you flush your sodium chloride. I mean, you label your sodium chloride as a flush, and then you label your antibiotics with a blue label so you can identify which ones. All right. Any questions so far? So you can see this. This is a burette. I know that back home, we do practice the use of a burette. Yeah. So in a burette label, it is also a small label, but it can be easily peeled off. The reason why is specifically in critical care where we use a lot of burettes and we incorporate a lot of medications there. The reason, and that's one of the reason why it can be easily peeled off. So during your face to face, specifically in Sydney, we do have these labels. However, we do have simulated labels as well across the state. The reason is we are not allowed to get this anymore from for educational purposes, because when there was high incidence of COVID, we actually have high demand for these labels also, and that is very understandable. So that is for your intravenous. So let's go back to the next one, epidural. So your epidural is similar to your intrathecal. The only difference is the border. So you can see that the border of intrathecal again is solid. The epidural is hatched. So in that case, as a newly registered nurse, we are not allowed to manipulate any epidural forms of medication or fluids. No, not fluids, medication. And it is a good to know for you that this is the label. So intrathecal epidural yellow. Difference is that they have different borders, and the intravenous is blue. Okay, so anything that you see as blue is called an intravenous, is for intravenous. Then we've got the next ones, subcutaneous. So the subcutaneous is color beige or brownish, and it's got a black beige hatch as well on the side. So what medications do you think, or IV fluids, could go in a subcutaneous route?
Heparin and insulin.
Perfect. Joanne as well did send a chat. Insulin, yes, that's good. So we do have insulin that is given continuously as a subcutaneous injection. We do have insulin that is given subcutaneous in a syringe. We do have heparin, dexamethasone, octreotide, um, what else, metoclopramide, that can also go subcutaneously. So any subcutaneous medication will need a label that is brown or beige in color. Okay, so how do you attach them in the syringe? It's the same as that of the intravenous ones, but the color is different. So if we go back to that to the medication. So that's for the bag. Usually, these are for like palliative patients, for example, who actually would need some fluids as per request of family members. So if they say, oh, I want my father to be hydrated. We don't want him to die of dehydration, for example. It's for comfort measures, and it's also to give, to make family feel at ease. And yes, definitely we can give fluids, and we can put it in a subcutaneous tissue and then run through the fluids there. So we can label the IV bag with your subcutaneous label. We do have the smaller ones, which is your for the smaller bags or for your syringes. So, say for example, your metoclopramide, if you want to administer that subcut, you do have your insulin, you do have your heparin as well. Question. In Australia, we do have pre-filled syringes of Clexane. Do we need to label them? Any idea?
I think no.
Why not?
I think the syringes come with the names, the pre-filled one.
So I'm just searching for Clexane. Let's go to images. Okay, so in Australia, our Clexane is already labeled. So let's go to this. So you can see that the syringes here already have labels. Okay, so there is no need for relabeling. because we are wasting our time. Not just we're wasting the 8 minutes in OSCE, but also we are wasting our time in the clinical area, because the purpose of labeling is to identify the medication. Okay, so if you can already identify the medication because it's already there, it's already labeled, then there is no point in relabeling it. Okay, so I hope that's clear, because when you go to your OSCE, you might be wondering, should I label or should I not label? Okay, go back to the principle that it is for medications that are not identifiable. All right, now we've got regional. So this is like for regional anesthetics. So it's color white with a black or yellow, black and yellow hatch on the side. Again, this is something that an entry level RN is not expected to manipulate. So it is a good to know for you. Okay, good to know that, oh, okay, this patient has a, say, regional anesthetics going on. At least you can see. Now, there are other routes where it doesn't belong to any of this. Example, who can give an example? The other injectable routes that we haven't mentioned. Anyone?
Intradermal.
Intradermal.
Mm,
What else?
mm.
Not very common in Australia for intradermal. Number one, we don't really do skin testing here, but yes, that is a very good thought. Intradermal medications. Very.
Intramuscular.
Yes, that's the very most common. Intramuscular. Intramuscular injections. We in Australia, it is not recommended unless there is no other way. Okay, if there is no other way, say for example, this patient needs IV antibiotics, say ceftriaxone, for example, and the patient's IV line, I mean, the IV cannula is, say, infected, and the patient has really a very bad IV site, and it's late at night. There is no one in radiology to actually insert a PIC line, for example, for this patient, and these patients need this medication now because the patient is very septic. Okay, so what does it mean? The benefit of giving an intramuscular injection is more than the risk, and therefore it is okay to give an intramuscular medication. Or this patient is going to theater, and maybe the doctor wanted to insert the cannula in theater, but would have a pre-op medication of, say, morphine and ondansetron, for example, and then we can give them as IM injection. So in this case, we are giving it intramuscularly, and therefore we use the orange syringe. Okay, very common. Another thing that is common in pediatrics is an intraosseous medication as well. Okay, so any fluids or medication that is given intraosseously through the bones, we label them with the pink medication label. Okay, so what does that mean in your OSCE? In your OSCE, because APRA and the NMBA has outlined the different medication routes, that is your intravenous that you will be using, and then you will have your subcutaneous and your miscellaneous. Okay, so intravenous, subcutaneous, miscellaneous. And what is that color? Your blue, your brown, and your pink. So open environment flush label. So when we say open environment, we do have two types of environment. Okay, so the first one is an open environment, which is the ward area. So this is what Audrey was saying a while ago. Most of the ward area, we call them open environment. We do have a close environment, which is obviously higher. It's a higher level RN, which is critical care, operation theater, and we do have labels um, that are actually sterile. Okay, so still the same. Colors are the same. There are smaller medications such as sodium chloride, which would say propofol, for example, or kind of anesthetics, bupivacaine, for example, and they write it in that kind of sample. For OSCE purpose, it is very important for you to know this normal saline because you'll be using this normal saline flush in every IV medication during your OSCE. So we do have some lines as well. Okay, so aside from the label itself, if they have a dedicated line, for example, you need to put this um, in the line or in the IV line. How does that look like? Anyone? Okay, so if you look at this photo, you can see that sticker is being stuck, is being applied in that IV line. Okay, so when you're actually hanging an IV fluids with your, say, normal saline, if that is a dedicated line for normal saline only as a maintenance medication, then you need to have that IV label as well. Okay, why? So it says here label near the injection port on the patient side. Why do you think so? Any reason? Do you think the national standards did have a reason for putting that in there? Just a guess. Christina, you're unmuting your
Yep.
microphone, so I would say you would like to share your thoughts.
So it's easily visible for the nurse to check if the IV fluids is the correct one that's hanging and attached to the patient.
Yes, that's one of the reasons. So it's easily visible. In what way do you think would it be easily visible?
Because it's near the injection port. So when you're administering, for example, when you're administering an IV medication and you have to check if it's compatible with the IV fluids, then
Perfect. That is what I was looking for. Just before you administer a medication to this port, okay, you see that port? Just before you administer that medication, what if it's dopamine in there? The purple dopamine. Okay, should you administer that medication? Of course, that will alert you. Hang on, this is dopamine. I'm giving furosemide. Are they compatible? So that is your safety as a registered nurse. Hang on, this is an IV heparin injection, and now I am giving, say, a dexamethasone injection. Are they compatible? Can I administer it here? Okay. Can I flush the whole heparin in one go and then administer my dexamethasone and then flush it and then restart my heparin? So that is actually um, a safety measure so that you will know that that line is a dedicated line for morphine or for a medication, pantoprazole infusion, for example. Okay, thanks so much for that thought, Christina. And during your NCLEX, not NCLEX, sorry, your OSCE, you need to make sure that you actually label. You need to label in your IV line, and it needs to be next to the port. Okay. There are also other like continuous infusion. So that's the morphine, propofol, dopamine. But if you don't have the sticker, there is a generic medicine label. So write down the medicine name. It could be IV ceftriaxone infusion for the next 24 hours. So you can write ceftriaxone. Or it could be, say, a chemotherapy, for example, and then you can write that chemotherapy, the name of the medication as well. Okay. Zara, thank you so much for dialing in and sharing your camera. That's really helpful. Thank you. Then you do have a catheter lock. So we do have like central lines that needs to be locked as well. So the reason there is to ensure that the nurses who are looking after these patients know that you did some locking of the catheter. Okay, so we know that it is there is heparin, for example, heparin lock in that situation. As an entry level registered nurse, we are not expected by the NMBA, according to the handbook, to manipulate central venous access devices or CVADs. However, it is a good to know skill for you. That you would know that there is a label of catheter lock. And then when you go to your OSCE, for example, if it comes out that the patient has a CVAD and catheter lock, it is a good thing for you to mention, because that is where they can the assessors would also know that you've got the knowledge for medication safety. All right, so let's move on. So you can see there that we do have intrathecal, which is yellow with a solid border. So that's the same as the medication label. We're talking about the lines label now. You have the intravenous, epidural, the central line, your regional. So they're actually almost the same color and format as your IV medication labels, as we have talked about in the previous slides. Your subcutaneous as well is beige in color or brownish. Intraarterial is don't know, red, and your miscellaneous, which could be your intramuscular, intraosseous, intradermal, can be your pink in color as well. All right, any questions so far before we proceed? How are you finding it?
Hi, Carissa.
Yes, Sapana.
Yeah, the class was nice and it was interesting, and I get lots of knowledge. Unfortunately, I have to attend my class, a uni class at 11. So, can I leave the class?
Definitely. This session is recorded, so you can revisit this as well. There are only 3 more slides that we will be talking, but yes, definitely, by all means, you can go and concentrate with your other class. But thank you so much for attending this
Thank you.
session.
Thank
All
you.
right, no problems. Okay, so let's move on. These are good to know. These are not injectables. However, it is a good to know labeling as well, because you might see this also. So you've got your enteral use, which could be your PEG or your NGT, and you can label them as well with green, and your inhalation. So that goes to your inhalers or your oxygen, for example. All right, let's proceed with an activity. So, and this will we will have 3 activities, and then we will finish the class. So how will your end procedure look like after the preparation? So this is your after the preparation, before the administration. So this is a part of the fluid order that NETA has made for our students. And this is a pretend patient, MacGregor Lovely, born on the 2nd of the 8th, 1980. Um, as I'm not sure if you know our educators, but I use Lovely, one of our educators, and Karen, who's here today as well. I chose their name. I just couldn't think of any name. But anyway, so how do you think this will look like if there is an order on the 25th of the 3rd, 2021, which is today? The indication for this IV fluid is for maintenance, and it is a 0.9% normal saline, 1 liter, with magnesium sulfate, say 10 10 milligrams per mil and millimoles per mil. And then you've got your 60 mil per hour of rate. Route is IV. How do you think that would look like? Anyone can describe it? Your end product after your preparation and before you administer? Silence in the room? Yes, Renu, you are unmuting yourself.
I think the label will be blue in color.
Yes,
It's the
perfect.
intravenous. Um, so we have to write every like max off also in the label,
Hmm.
and to bring it.
Good. That is very good. Let's put that in a picture. So that's how it is. Ta-da! So that is your IV sodium chloride with your label that also says it's got your magnesium sulfate. And of course, definitely you need to have um, your intravenous line label as well. Okay, so during your OSCE, if this will come up that you need to do this, your end product should look like this. Okay, and what does that mean? If you only do this, you miss that. It is not best practice. So always look from the IV fluid itself straight to the IV line. Okay, well done, Reno. Good try. Um, This is the next one. How will your end procedure look like after your preparation, before your administration? So you have your patient. So this is another sample of a medication chart that I just cropped. So this is your patient, Lovely McGregor, who lives in 169th Street, Happy Suburb. How good is that? And she's allergic to metoclopramide. So there is a ceftriaxone order of 1 gram IV. The pharmacy has written to dilute it in 20 mils. So there could be reasons here. Maybe ceftriaxone, the patient's vein is really sensitive, and therefore we need to dilute it with 20 mils, and it's for leg cellulitis. What do you think would your end procedure product be like? Who wants to try? We have Audrey, Zara, Christina, Sapna, Mark. I know you are you do chat, so maybe if you're not comfortable to talk, you can write down in chat. How would it look like? Joanne, Jane. Hopefully, Jane, you're still up in Qatar at the moment. I would presume it's already 3 o'clock in the morning there. May, Sonia, how do you think it would look like? So if it's ceftriaxone, it's IV, what do you think is the color of the label? Yes, Audrey.
I think it would look like it will be in a syringe
Mm-hmm.
and it needs to be diluted in a 20 ml. So if we can, I'm just not really sure, but
Yes.
we could use a 20 ml syringe, and then we will be putting the blue tag with the
Mm-hmm.
hatch border, and then all the details of the patient must be there, including the allergy, most especially. Yes, that's it. I haven't given an IV medication in the UK since
Yeah.
I arrived, and it's been um, I think 3 years since I've given an IV medication. It was way back in the Philippines. So yeah.
Yeah, but Good guess. Ta-da! You could either use the one on top or the one below. So you can see that it is in a 20 ml syringe, either it's flagged or being wrapped for as long as it is labeled. My recommendation is, and this is my recommendation to all students, is to flag it so that you can still see the calibration. Okay, but definitely if you wrap it as well, there is nothing wrong with that. It is not minus your OSCE point because it is a recommendation by the national standards. Okay, well done, Audrey. That's really good guess. Now the last one. How will your end procedure or the product look like after your preparation, before your administration? So this is the same as your the same patient who lives in 169th Street, Happy Suburb, um, and who's still allergic to metoclopramide. The order is heparin subcut 5,000 units BD. And this is a correct order. By the way, this will be another kind of demo class as to the abbreviations that we use. Um, some practitioners would still write S/C, which is now not best practice. So it should be the word subcut, okay? Or if it's sublingual, subling.
Yeah. Can I
So
ask you one question?
yes,
Will there be any like tricky questions regarding the prescription, like mistakes in the prescription? We have to check the while doing the practice in the OSCE.
that is something that I cannot answer because I really don't know what will come out in OSCE. As we said, it's a very regulated exam, and it is also a it is an exam that no one will know what will come out.
Yeah.
Yeah, so there's a lot of pool of questions. So what we would recommend is that you should know the best practice. So in this case, if that is written as this one, you wouldn't know if it's SL sublingual or SC subcut. As a registered nurse, would you administer a medication like that? Would you be able to administer?
No.
No. So definitely this is something that is a safety issue. And if I am the registered nurse, I won't proceed. And during your OSCE, if that comes out, the best thing or the best response that you would give is as per the standards, as per standard 4, which is medication safety, because we will be teaching you in OSCE the powerful words that you're going to inject during your test so that your assessor will know that you've got the knowledge as well. And I know Renu, you know this already, and these are the powerful words that we use. So we can say, as per national standards, in standard for medication safety, using this abbreviation is not the best practice. I wouldn't know if this is subcut or sublingual, and therefore I have to escalate this to the prescriber before I administer the medication. Okay, so that is a very safe practice. And if I am the one who is assessing you, I would say, oh, thank God you didn't give me heparin sublingual. Okay, so if I am the assessor, I would say, oh, I would definitely trust you as my nurse because you haven't given this heparin to me sublingually. Okay, at the end of the day, the patient will actually tell you, oh, they never put that here. They always inject it here in my tummy. Okay, but then as a registered nurse, you need to have the best practice. You need to know and you need to perform the best practice because that is what is expected of you as a registered nurse. But that's a very good question. That is another demo class though. Okay, so in this case, how would your medication look like? So let's start with a color. What is the color of the label? Because you need to label this.
Is it green?
Sorry, Christina, you were saying something.
Is it green? Pale
Did you
green?
say green?
Yes. I'm not sure.
Okay, any
Joanne said brown in the chat box.
Okay, so Joanne, yep, you said brown. Yes, it is brown. Christina, the green one was our enteral. Okay, so if we look at our good to know, the green label is for enteral use. Okay, and it's not for injectable. So our heparin, so we've got heparin here, and it is subcut. And Joanne, you said it's brown. Yes, tada, it would look like that. Okay, so um, it's just the nursing is an art. There is no picture that I found over the internet, so I just attached that sticker in there. So yes, it is brown and it has to be labeled, and the calibration should still be seen. So you need to flag it. Okay, so it's a brown subcutaneous use only um, label. I haven't included the intramuscular here, but who can tell me the color of intramuscular?
Pink.
Pink, perfect. So if that is intramuscular, then your syringe will have a pink label also. Very good. Um, for our reference, we use the Australian Commission on Safety and Quality in Healthcare. That is the 2017. And there is also the National Safety and Quality Health Services Standards Guide for Hospitals, second edition. So if you are familiar with that, you can see in your handbook um, you can see that that's the number one source recommended by APRA and the NMBA. So what does it mean? Definitely, this will be one of the questions in your OSCE. It might be presented in a different way, but the knowledge there is labeling of medications. So that is one of the resources. All right, I think that's the end of our session. Do we have any questions, realizations, insights, experience, or whoever wants to share? Is there anything that you'd like to tell us?
I have one question again. Just like Lexion, we don't have to label the pen insulin. Uh, is it right? The pen insulin.
Yeah, so with your pen insulin, this is already pre-filled. So your the pen actually has the name already of the I mean the insulin itself that you put in the pen. Okay, so say for example Lantus or Protophane. So you already have that. Your responsibility as a registered nurse is to make the label visible. So it already has the name of the medication. So what you need to do is just to make sure that prior to injecting, you know it is actually protophane. Again, it goes back to the safety rights of medication administration. Are you giving the right medication? So you need to check that you can actually see that that is protophane, for example. So no need for label, but it should be visible. It should be identifiable.
Thank you.
I'm just checking. So you can see here, protophane. So when you are actually, um, hopefully this one. So that already has the name of the medication itself. If you can see that, just make sure that it is visible. Okay, you can have another one. It doesn't show the medication, so probably that one, Novolog, for example. So you need to make the label visible so that you can see prior to the administration. Okay, that's another kind of pen. Did I answer that question, Renu?
Yeah. Thank
Yep,
you.
perfect. Any other questions? I like how Google just give you, the images straight away. It's more understandable. Any questions from the group, or even some highlights, like, what have you learned out from this information session or this class?
Um, I I just learned how. I mean, the session is very informative, and I just learned the difference because I haven't. I've been in the ward a few times, and I haven't seen the same color coded labels that you have in Australia, which actually is. I just realized now it's more useful, and even from afar you can see how that medication should be administered, and it would be a really big help to distinguish the different um, medication routes that you need to be mindful of, especially I mean not just for yourself but for your colleagues as well. So yeah, I'm really happy that I've attended. Thank you so much, Mr. Risa and Ms. Karen, for having me.
Thank you very much, Audrey. I am really happy and pleased to hear your information and your learning. So this is what the students were actually telling us, that there are things that they need to unlearn from where they used to practice, and there are things that they have to learn in an Australian standard. And this is the reason why the preparation class is very essential, because there are a lot of practices that we actually do back home that we think it is, the gold standard, but Australia itself has set 8 standards. And if you were there during the introduction itself, this standard 4 actually has 7 or 8 components of it, and this is just one of the 8 components that we are actually we are actually discussing. So thank you so much for that realization. That's really good. Who else would like to share just one thing that they've learned today? I think that is the reward for us as educators, when we actually know that there are learnings. Zara, would you like to share? You're on mute though, Zara. Zara, can you hear us? Or maybe it's me who's. Can you hear me, guys?
Yes, we can hear you.
Yes. Zara, would you like to share one learning that you have? Just one.
Hi everyone. So this class was very informative. Thank you so much. And I didn't know about medication labeling in Australia. In my country, it was very different with this. So thank you. And I think uh, we need to um, participate in the preparation class before we attend to OSCE exam.
Thank you so much,
Thank you.
Zara. There's just a chat from Joanne. I will definitely recommend you to my friends who just passed the NCLEX. It is a very informative class, and you have shown mastery with all the practices in ideal and standardized manner. Um, oh, sorry, there's a PS there, and I just realized. Um, so, just very brief about our OSCE program. So, before we go, I just wanted to let everybody know what you would be able to get from the program. So this is a demo class. Definitely, it's not the one that you will entirely get. This is one part of what you will be getting in the classes. So the class is 2 weeks of online, and we deal with a lot of scenarios. We do break you into break rooms as well so that you can interact with other students with different scenarios. So there is peer teaching done in online class as well. Then you will have and during your online class, by the way, we will cover all the skills that APRA and the NMBA has recommended. If you can see in your handbook, say for example, physiological observation, in your physiological observation, there are different components of a physiological observation. Okay, so that could be neurological, neurovascular, pain assessment. So we will be tackling each physiological observation. So then you'll have your 5 full days of hands-on training in our simulation laboratory. So we do deliver it in Brisbane, we do deliver it in Sydney, we do deliver it in Melbourne, and also in Adelaide. So we have delivered in Brisbane, Sydney, and Melbourne. And next week, we are going to deliver it in Adelaide. So that's quite exciting. And it's 5 full days of hands on training. Our students, when they come during their hands on training, they are already very good because of the online session that they have attended, and they also receive the workbook that has a lot of activities as self-directed learning as well. As adults, I believe that everyone is very motivated to pass this test, and therefore very motivated to complete their workbooks as well. Um, Few students have said that the workbook is very good, but majority of the students did say that it was very essential for them. So if you would like to pass the OSCE, we would like you to pass as well. Same as our level probably is the same. And I think everybody who's here today would love to pass our OSCE. So we would recommend that you complete the workbook that we give you. So another resource is that we have the pre-recorded videos of skills in your learners portal. So there are videos there that you can have a look, you can practice side by side, and the videos as well that we request you from your workbook, you can do it side by side from that video. The video that you actually submit to the course coordinator, Karen, is actually your finest skill already during your practice. That's why when you go to your face to face, you're already very equipped. Then you have your handbook, or we call it the workbook. We are now on version 6 of that. And the reason is we continuously improve the content of your workbook. You also have the competency assessment tool. So if you read the APRA, the OSCE RN handbook from APRA, it says there that you will be graded according to evidence-based assessment tools. So we are also doing that to you in your face-to-face because we want you to already feel how it is to be assessed with your OSCE. We do have some tools, pathways, resources, and some charts. If you can see in our activity a while ago, I've shared a snippet of those charts. Those are just few of the charts that we actually share to the students. And of course, it is done online and face to face. So very happy for you to actually contact us for more information and further details. Our very friendly Roji, who is in our admissions, actually receives your call. So it's 1-300-00 NETA or 6382. For those who are overseas, you can contact us through email, or you can also contact us with our WhatsApp number, or even in our Facebook page, NETA, NETA OBA. If you would like to seek further information or would like to attend more demo classes, we are more than happy for you. just follow our Facebook page and you can register from there. Karen, is there anything else that you'd like to add?
So our program, just to highlight, is offered to you for the next 6 months. Meaning to say, even if Carissa told you right now that our online is given for 2 weeks and 5 days of face-to-face, you could repeatedly do that for the next 6 months. And if you're currently, overseas, it's not of your fault that the border is actually closed. So we are letting you attend the online class repeatedly. So your 6 months count will, your limited access for 6 months will count once the border opens. Meaning to say, you could attend the classes online every month as you desire until you become expert of the skills. Okay, so once we see you face to face, definitely you'll be very, very good and confident when you are going to demonstrate the skills. So since we are always going back to our mission that we want our students to be 100% passing, so we are, in continuous support of our current student and our future student. So that is the best that we could offer when you enroll with us in NETA.
Thanks, Karen. To those, by the way, who are outside of Australia, who's listening and who's with us right now, there will be an information session from one of our partner immigration agency who's done few exemptions already. If you would like to listen to the visa exemptions and travel information about, coming to Australia for your OSCE, please feel free. It is in our Facebook page, Neta OBA. Please register there, and we will see you later. Tonight, I think that's for 5 o'clock tonight. So, yeah, if you'd like to join, that's 5 o'clock Sydney time, Sydney, Melbourne time. All right, guys, thank you very much for your time and thank you for listening. We are very happy to hear your learnings for today, and I think that is the reward for educators. So thank you very much, and yeah, let's keep in touch.
Thank you.
Thank you.
Have a
Bye
good day
bye.
ahead. Bye.
Bye. Thank you, everyone.